Going to be another one of those ripe drugs, RIPE. Ethambutol is dispensed as a pure positive enantiomer, which is 200 to 500 times more potent than the racemic mixture. So this is one of the unique cases where an older drug is actually separated into enantiomers. It's going to be an antimycostatic agent as well, so it's going to be taken up by these bugs. And what it does is it blocks arabinosyl transferase. Arabinosyl transferase is the bug's enzyme that takes these arabinopyrosyl sugars and converts them to the arabinogalactans that we talked about. If you recall, the importance of the arabinogalactans is that they are the outside of the peptidoglycan layer, and they serve as the matrix that holds the mycolic acids to the peptidoglycans. Okay? So these arabinogalactans are going to serve as this matrix that holds the mycolic acids in place. Okay? And so ethambutol blocks the mycobacterial enzyme that synthesizes those arabinogalactans. Resistance to ethambutol occurs due to a single point mutation, change in one nucleotide, in the MB gene that encodes for the enzyme arabinosyl transferase. Okay? So ethambutol binds to that enzyme, and then if it mutates at that one site, then ethambutol will no longer bind. So essentially what you're having here is a drug that inhibits arabinogalactan synthesis, and in doing so, mycolic acids have no place to be attached. Okay? So again, it disrupts the integrity of that membrane. Some major side effects of this drug, the first one is optic neuritis. This leads to decreased visual acuity and loss of the red-green color differentiation in the eye. Okay, this is essentially an optic neuropathy. This is a consequence of the inflammation of the optic nerve. Okay, so it's an inflammation of the optic nerve, and that's going to lead to this visual acuity loss and loss of the red-green color differentiation. So essentially making someone colorblind. Another reason why ethambutol is dispensed as the pure plus enantiomer is because the racemate is even more potent in causing this neuropathy. Okay, so the dextroisomer is less harmful, and that's why the dextroisomer is pulled out and dispensed by itself. This is another one of those dose-dependent, so 15% of those on the low dose, of those on the highest dose, and then it kind of trickles down to 1% on those on the low dose, so dose-dependent neuritis. The intensity of this visual effect is also dependent on how long the person stays on the drug. And so the longer the duration that they're on this drug, the more intense the visual loss will be. Of course, the question is this reversible or is it permanent? It's usually reversible, but it depends on the degree of damage. If the optic nerve has been damaged to such a degree that that damage cannot be reversed, then the loss will be permanent. But it's usually going to be reversible. This is essentially the thing that you're looking for here. With ethambutol is you're looking to see if that patient has any visual problems. And if so, the drug is typically discontinued before it turns into a permanent visual problem. The reason why this happens is because of what goes on in the optic nerve's mitochondria. Okay, in the optic nerve's mitochondria. And so you guys all know how this works in the mitochondria. You get generation of ATP due to the various cycles, due to the Krebs cycle that's in there. So the generation of ATP is dependent on copper, because copper is a cofactor for the cytochrome C system. Okay? So it's dependent on copper in the mitochondria. If you look at the structures of ethambutol here, here's I only show you one, so this is the structure. But here I'm showing you 2 molecules of ethambutol. And what's this M? What's this M? Metal. Metal. Copper is a metal, right? And so what you're seeing here is chelation of the copper in the optic nerve mitochondria. And so if copper is chelated, then it's not available to act as a cofactor for the cytochrome C oxidase. And so if copper is not available for cytochrome C, then the entire oxidative phosphorylation process in the mitochondria is disrupted, and you're not getting ATP generated. So essentially, without the proper copper levels, there's no ATP, and if there's no ATP in the mitochondria, then the cells will will die, will start to die off. And so that is how the mechanism of this optic neuritis occurs. Questions? Okay. Pyrazinamide is, I believe, the last of those ripe drugs. We've covered isoniazid, rifampin, ethambutol, and now pyrazinamide. Pyrazinamide exhibits antibacterial effects at a slightly acidic pH, and the tuberculosis bug usually resides in macrophages, which happen to have a slightly acidic pH. So this drug is pretty selective for those macrophage-residing tuberculosis bugs. This pH of a macrophage is on the order of 5.5 or so, 5.5, 6, slightly acidic. So the bacteria, again, express an enzyme. Okay. Now, this enzyme is called a pyranidamidase. Pyrazinamidase. You get it, right? This enzyme takes the drug pyrazinamide and converts it to this active acid metabolite, but that is not the purpose of the enzyme. Okay, so the enzyme is named after this drug, but it does something else for the bacteria. Okay? This is a bacterial enzyme, so the target selectivity is going to be fairly good because the conversion of pyrazinamide to the active acid is dependent on this bacterial enzyme. Okay? The target of this drug is not yet known. It's not INHA, that target that isoniazid inhibited. The target is not yet known, but what happens in the end is that you inhibit mycolic acid synthesis. But it's independent of that INHA that isoniazid inhibited. It's not that same target. Okay? If used alone, resistance occurs through what mechanism, do you think? So resistance occurs through what? Ashley, what did you say? So the INHA is making mycolic acids, but this is independent of that system. Okay, so it doesn't go through that INHA pathway. So what is the only thing I told you that this drug is dependent on? The enzyme, right? So this enzyme, this bacterial enzyme, if it mutates, it's not going to recognize pyrazinamide. So this pyrazinamidase, if it mutates, it won't recognize the pyrazinamide, so it won't convert it to the active moiety that it then does its unknown thing to decrease mycolic acids. Okay. So again, combo therapy to prevent that resistance mechanism. Okay, untoward side effect of this that you need to write down is liver toxicity. Hepatic function must be checked before a patient started on it to make sure that the hepatic function is normal. and the drug is DC'd if there's any evidence of hepatic dysfunction while they are on it. All right, one final drug I'm going to cover with you. This is an agent of last resort, really, for TB, cycloserine. Cycloserine is really TB active only. It does have some activity at non-mycobacterial species, but TB activity only for our purposes. It's typically going to be reserved for combo use when everything else has failed due to resistance. The mechanism of this is that it inhibits D-alanine racemase and D-alanine ligase. These things are important in the bacterial's ability to synthesize what? Yeah, peptidoglycan, because D-ala is what is the conserved piece of the NAM chains. So D-alanine racemase takes L-alanine and makes D-alanine out of it, and D-alanine ligase puts together those D-ala pieces. Okay? So this is going to be involved in the peptidoglycan. Its reserved nature is due to the CNS effects. It is an NMDA receptor agonist, and it causes a decreased synthesis and metabolism of GABA. So it's never used in patients with a couple of things. History of seizure is one of them, because it's going to cause seizure. And the other consideration is patients that are depressed or anxious, that have underlying anxiety or depression. It does increase the suicide risk. It causes increase in nervousness, paranoia, and psychosis. So there's some CNS issues here. So avoiding in patients with depression, anxiety, avoiding in patients with a history of seizures. And again, that's linked to these two things, NMDA receptor agonism and decreased GABA. So if you decrease GABA, you're affecting the seizure threshold, right? Because you don't have that inhibitory neurotransmission. All right, so that's the last drug. I want to say a few words about extensively drug-resistant TB. This is now moving from MDR, which is multi-drug-resistant TB, to XDR TB. And this is relatively rare. It's essentially resistance to almost all the drugs used to treat TB, including isoniazid, rifampin, fluoroquinolones, and at least one of these other ones. Amikacin, kanamycin, and capreomycin is one that we don't talk about. It's not used much more. Special concern here for immunocompromised patients, because it's, these people are more likely to have an active infection. Okay? So really the big difference between TB and XDR TB is that these isolates of tuberculosis don't respond to these drugs. It becomes very difficult to treat XDR TB. And you guys may remember several years ago there was someone on an airplane that was said to have XDR TB, and we went into a frenzy, right, because this guy was allowed to get on an airplane and travel around the country. And the fear was that it spread on the airplane, and then every one of those people, when they go home, they're going to spread it, and then you're going to get the spread all over the place. So air travel is really a big problem for a lot of infectious diseases, but TB is one of them. So the highest risk for developing XDR TB are TB patients who don't comply with their treatment. Because by not complying with their treatment, they are doing what? Selecting for resistant isolates to grow. Okay? They are selecting for resistant isolates to grow. Those that have excuse me. Those that have recurrent TB, those that come from areas of the world where MDR TB is common, and those that are in direct contact with MDR TB patients. So family members, physicians, pharmacists. Okay? So again, relatively rare, but there are some groups that are at high risk. These are the numbers of extensively drug-resistant TB, and I like the way that CDC spelled tuberculosis here. In the United States from 1993 to 2006. So you can see that this does not represent overwhelmingly scary numbers. Okay? So very few cases. 11 out here, 8 in New York State, 19 in New York City. Again, why 19 in New York City? Because John F. Kennedy Airport is the major international arrival destination from all over the world. Okay? So mainly due to travel. Okay? So very rare. It's not this huge deal that it was made out to be in the media. And then the case count is shown here. You can see 2009 there was no cases. Okay? That's not rare. That's nothing. Okay? So very few. Again, the point of this is to show you that this is very rare. Okay? So not anything to get terribly up in arms over. Now, how do we treat XDR-TB? 30% of the people that have it have been cured, but the extent of the success depends on drug resistance, the severity, and whether or not the patient has a compromised or normal immune system. Okay? So there's nothing special about treatment of XDR-TB other than finding the right combination of drugs. Like I'm not here to tell you that now we got another drug that we can use for XDR-TB. It's not the case. We don't have anything other than what's already in our arsenal. Okay? But finding the right combination of drug has led to successful treatment. So it's not incurable. 30% of the people do get it cured. But again, that depends on their immune system, depends on what drugs they've taken before, depends on how compliant they've been to their therapy in the past, things like that. All right? And finally, HIV and TB. Now I'm not going to go too in depth about this because we haven't learned about HIV yet. But this is kind of just the teaser to introduce the topic to you so that when we do talk about HIV, some of this will make a little bit more sense. So there's about 12 million people in the world infected with TB and HIV. In the U.S., 1 out of 5 people with TB also has HIV, so 20%. The primary cause of death in these patients is the TB. HIV never killed any patient. They always die of something else. We'll talk about that on next Wednesday or so. But these patients don't die of HIV. HIV suppresses their immune system and they die because of infections like TB. Okay? It causes 1/3 of all HIV deaths. So this is a big deal. TB and HIV is a big deal. Okay? Most of the cases are extrapulmonary. Again, normal immune systems, just as I've said a few times now, those with normal immune systems typically don't get extrapulmonary TB. Okay? Immune compromise is one of the factors that can lead to extrapulmonary TB. There's a greater likelihood of co-infection with HIV patients yielding active TB. So these patients with HIV have a greater likelihood of getting an active TB infection. Remember I said that in general, 1 out of every 10 cases of TB is active. 9 out of 10 people are carriers. Well, if you have HIV, it's not 1 out of 10. You're likely to get an active infection. Okay? So those HIV patients are going to have a higher risk of getting active infections rather than just being latent carriers. Those patients with MDR-TB and HIV together appear to have more rapid and deadly disease courses than patients with MDR-TB without the HIV. So again, HIV co-infection with MDR is going to lead to a worse outcome. There's a huge difficulty in diagnosing these patients. Why is that? Okay, so it's extrapulmonary, so that makes it tough. They frequently have disease symptoms similar to those with TB, and they may not react properly to the PPD test because their immune systems are compromised, right? So if patient's always been HIV negative, always been TB negative, right? They've always had a negative PPD skin test, but then they get HIV and their immune system's compromised and they get TB. Well, what's making the antibodies? But their immune system's compromised. They're not making the antibodies, right? So this is difficult to diagnose them based on a PPD test because the immune system is not making antibodies to be detected by the PPD test. The other challenge here is rifampin interacts with the protease inhibitors and the reverse transcriptase inhibitors, so we have to use rifabutin instead. And we'll talk about some of the exceptions, like ritonavir. We'll talk about ritonavir next week, but you'll also see in the guidelines where the use of ritonavir can be of help with this rifampin issue. Okay, so nothing big there. I just want to kind of introduce some of the general concepts of HIV and TB to you. Question? Okay, tell me specifically. So the question is, do we do anything prophylactically with TB, specifically in HIV patients? Good question. I don't know. I don't know about that. Yeah. So typically, prophylaxis can be done in normal people. So if I had to guess, I would say, yeah, in an HIV person they would do it, but I don't know for a fact that that's done. What other questions? All right, that's all I got. We're going to break out of here early. So remember, Monday exam in here and in 175, 7.